Traps number 3. Microbiology and Immunology. The chapter with the longest lists and the smallest margins. 2 organisms that cause the same syndrome, 2 antibodies that attack the same gland, 2 deficiencies that produce the same infection. 50 questions, each turning on the one feature that tells them apart. Which organism is responsible? A 54-year-old man with poorly controlled diabetes and ketoacidosis develops facial pain, black necrotic turbinates, and proptosis. Biopsy shows broad, ribbon-like hyphae with no septations, branching at wide 90-degree angles. Read the command. Which organism? 2 invasive molds cause angio-invasive disease in immunocompromised hosts, and the histology separates them in one glance. The 2 invasive molds are told apart by their hyphae. Mucormycosis, Rhizopus, Mucor, Obsidia has burrowed, ribbon-like, non-septate hyphae that branch at wide 90-degree angles, and it has a striking predilection for patients in diabetic ketosis because the acidic, iron-rich environment favors fungal growth. Aspergillus has narrow, septate hyphae, branching at a Q45-degree angles and typically infects neutropenic or transplant patients. Both invade blood vessels and cause tissue necrosis, but the septation and the angle assign the diagnosis. Choice A wrong. The correct answer is C. The urgency is what makes this more than a histology question. Rhinoorbital cerebral mucormycosis spreads through vessels into the orbit and cranial vault within days, and survival depends on aggressive surgical debridement alongside amphotericin B. Antifungal therapy alone is inadequate. Aspergillus has 3 distinct clinical phases worth separating: invasive disease in neutropenia, an aspergilloma colonizing a pre-existing cavity, and allergic bronchopulmonary aspergillosis in asthma and cystic fibrosis. If you see, an invasive mold leads to count the septations and measure the branching angle. Which treatment is appropriate? A 47-year-old man with poor dentition develops a slowly enlarging jaw mass that drains through a sinus tract onto the skin. The drainage contains yellow granules. Gram stain shows branching filamentous rods that are not acid-fast, and culture grows only anaerobically. Read the command. The appropriate treatment. 2 filamentous bacteria look alike on gram stain, and each has its own drug. Actinomyces israelii is an anaerobic, non-acid-fast branching rod that colonizes the oral cavity. After dental trauma, it forms slowly progressive abscesses that burrow through tissue planes and drain through sinus tracts, discharging the yellow sulfur, granules that are its signature. It is exquisitely sensitive to penicillin. Nocardia is its mirror image, aerobic, partially acid fast, acquired from soil, causing pulmonary and cerebral disease in immunocompromised hosts, and treated with sulfonamides. The mnemonic SNAP holds the pairing, sulfa for nocardia, actinomyces for penicillin. The correct answer is E. 2 features assign this case beyond doubt and are worth checking in any filamentous organism: stem, oxygen requirement, and acid fastness. Both organisms are branching filamentous rods that can be mistaken for fungi on a quick look, and both cause chronic suppurative disease, but their habitats, hosts, and treatments diverge completely. Choice A is the correct drug for the wrong organism, which is precisely the trap this pair is built to spring. If you see branching filamentous rods leads to ask aerobic or anaerobic, and acid fast or not. Which defect explains his infections? A 3-year-old boy has recurrent abscesses caused by Staphylococcus aureus, Serratia marquescens, and Aspergillus. A dihydrohodamine flow cytometry assay is abnormal. Read the command. Which defect? The organism list is the clue, and it points to one specific step of killing. Chronic granulomatous disease results from a defect in NADPH oxidase, so phagocytes ingest organisms obligingly supply their own hydrogen peroxide, needed to kill them. The infections that result are specifically with catalase, positive organisms, Staphylococcus aureus, Serratia, Nocardia, Burkholderia, Aspergillus, because catalase-negative organisms obligingly supply their own hydrogen peroxide, which the catalase-negative organisms obligingly supply their own hydrogen peroxide, which the phagocyte can still use. The dihydrohydamine flow cytometry assay, which has largely replaced the nitroblue tetrazolium test, measures exactly this respiratory burst. The correct answer is A. The pattern of organisms is the most efficient way to localize an immunodeficiency, and each choice here corresponds to a different pattern. Absent B cells give recurrent encapsulated bacterial infections after 6 months of age. Complement C5 through C9 deficiency gives recurrent Neisseria infection specifically. Leukocyte adhesion deficiency gives delayed umbilical cord separation with no pus formation, and absent T cells give viral, fungal, and opportunistic infection. Reading the organism list first narrows the answer before the assay is even considered. If you see recurring catalase positive infections leads to thin chronic granulomatous disease. Which pathway and which T cell subset are involved? A virally infected cell presents fragments of a viral protein synthesized within its own cytoplasm. Read the command, which pathway and which subset. Antigen presentation splits by where the protein came from, and everything else follows. Endogenous antigens, proteins synthesized inside the cell, whether viral or tumor derived, are degraded by the proteasome, transported into the endoplasmic reticulum by TAP, loaded onto MHC CLS1, and displayed to CD8 cytotoxic T cells which kill the infected cell. Exogenous antigens, proteins taken up from outside by phagocytosis, are degraded in endosomes, loaded onto MHC class II, and displayed to CD4 helper T cells. The arithmetic mnemonic keeps the pairing straight. Class 1 times CD8 equals 8, class 2 times CD4 equals 8. Choices A, B, and C mismatch at least one element. The correct answer is D, where each molecule is expressed, follows the logic of its job, and is separately testable. MHC class 1 appears on ALL nucleated cells because any cell can become virally infected and must be able to signal that. MHC class 2 appears only on professional antigen presenting cells, dendritic cells, macrophages, and B cells, because only they need to instruct helper T cells. Note also that platelets carry class 1, but red cells carry neither, which is why red cells are not directly targeted by cytotoxic T cells. If you see, an antigen presentation question leads to ask first where the protein was made. What is the outcome for that T cell? A naive T cell engages a peptide, MHC complex, on a dendritic cell through its T cell receptor, but the dendritic cell has not been activated and expresses no B7. Read the command, the outcome for that T cell. Activation requires two signals, and the consequence of receiving only the first is a specific and named state. T cell activation requires TW-independent signals. Signal 1 is antigen recognition. The T cell receptor binds peptide presented on MHC. Signal 2 is co-stimulation, B7 on the antigen. Presenting cell binds CD28 on the T cell, and B7 is only expressed when the presenting cell has itself been alerted by a pathogen signal. Receiving signal 1 without signal 2 does not merely fail to activate the T cell, it renders it aergic, functionally unresponsive to that antigen even if it is later presented properly. This is a central mechanism of peripheral tolerance. The correct answer is B. The co-stimulatory axis is also where modern oncology intervenes, which makes it worth understanding rather than memorizing. CTLA-4 competes with CD28 for the same B7 molecule, but binds with higher affinity and transmits an inhibitory signal. PDD1 on T cells is engaged by PDD-L1 on tumor cells to shut the response down. Checkpoint inhibitors block these breaks and restore anti-tumor immunity, at the cost of autoimmune toxicity, which is the predictable consequence of removing peripheral tolerance. If you see, antigen recognition without co-stimulation leads to thin energy, not activation. Which mechanism explains this? A 22-year-old woman using tampons develops fever of 39-28 degrees C, diffuse macular erythroderma, hypotension, and vomiting. Blood cultures are negative. Laboratory studies show massive polyclonal T cell activation with high interleukin-2 and tumor necrosis factor. Read the command. The mechanism. Two toxins produce shock through the immune system. and they engage entirely different receptors. A Superantigen binds the outside MHC class II and the outside of the T-cell receptor beta chain simultaneously, cross-linking them without any antigen-specific recognition. This activates a huge polyclonal fraction of T-cells at once, up to 20%, releasing a flood of interleukin-2, interferon gamma, and tumor necrosis factor that produces the capillary leak, erythroderma, and shock of toxic shock syndrome. Because the toxin acts at a distance, blood cultures are typically A-negative, which excludes choice D. Staphylococcus aureus TSST1 and Streptococcus pyogenes. Exotoxins are the classic examples. The correct answer is C. Choice A names the other great mechanism of toxin-mediated shock and is the discriminator worth holding. Endotoxin is the lipopolysaccharide of gram-negative cell walls, and it acts on macrophages through TLR4 rather than on T cells, releasing interleukin-1, interleukin-6, and tumor necrosis factor. Both produce fever, hypotension, and multi-organ failure, but one starts in the T-cell compartment and the other in the innate compartment, and the gram stain of the offending organism usually tells you which. If you see shock with polyclonal T-cell activation in negative cultures leads to think superantigen. Which hypersensitivity types are these? Two autoimmune diseases are compared. Disease 1, antibodies bind acetylcholine receptors on the muscle end plate, blocking transmission. Disease 2, antibody-antigen complexes deposit in small vessels and glomeruli, activating complement. Read the command. Which hypersensitivity types? Types 2 and 3 both involve antibody, and the difference is where the antigen is when the antibody finds it. T, Y, T, E. Hypersensitivity is antibody directed against an antigen, fixed ED, on a cell surface or in tissue. The antibody binds its target directly, and damage occurs where that target lives. Myasthenia gravis, Graves' disease, autoimmune hemolytic anemia, Goodpasture syndrome, and rheumatic fever all belong here. TYP3 hypersensitivity involves antigen and antibody meeting in the circulation to form immune complexes that then deposit in vessels, glomeruli, and joints, activating complement and drawing in neutrophils. Serum sickness, lupus nephritis, and post-streptococcal glomerulonephritis belong here, so choice A inverts the pair. The correct answer is B. Type 2 subdivides usefully by what the antibody does after binding, which explains why diseases in the same category look so different. It may destroy the cell, as in autoimmune hemolytic anemia, be a lock, a receptor, as in myasthenia gravis, or stimulator receptor, as in Graves' disease, where anti-TSH receptor antibody mimics the hormone. The last is the reason Graves produces hyperthyroidism rather than gland destruction, and it is a frequent second-order question. If you see an antibody-mediated disease leads to ask whether the antigen was fixed in place or floating in blood. Which statement about their antibodies is correct? 2 patients have thyroid autoantibodies. Patient 1 has a diffuse goiter, exophthalmos, suppressed TSH and HIH radioiodine uptake. Patient 2 has a firm goiter, elevated TSH, and biopsy showing lymphocytic infiltrate with germinal centers. Read the command. Which antibody statement is correct? Both diseases are autoimmune thyroid disease with antibodies, and the antibodies do opposite things. Graves' disease is driven by thyroid, stimulating immunoglobulin, an antibody against the TSH receptor that mimics the hormone. So the gland is continuously driven, thyroid hormone rises, TSH is suppressed by feedback, and radioiodine uptake is Hidge. The same antibody stimulates retroorbital fibroblasts, producing exophthalmos. Hashimoto thyroiditis is driven by antithyroid peroxidase and antithyroglobulin antibodies with cytotoxic T-cell infiltration that destroys the gland. So hormone falls, TSH rises, and biopsy shows lymphocytic infiltrate with germinal centers and Hürthle cells. Choices B and C each reverse 1/2. The correct answer is E. Radioiodine uptake is the most efficient discriminator when hyperthyroidism is the presentation, and it separates a third condition worth recognizing. Graves shows Hidge uptake because the gland is being driven, whereas thyroiditis, subacute the core vein. Painful and postviral shows LOW uptake because preformed hormone is leaking from a damaged gland that is not synthesizing. Hashimoto also carries an increased long-term risk of thyroid eye lymphoma, which is why a rapidly enlarging gland in that setting warrants attention. If you see thyroid autoantibodies, leads to ask whether they stimulate the receptor or destroy the gland. Which type of rejection has occurred? A patient receives a kidney transplant. Within minutes of vascular anastomosis, the graft becomes mottled, cyanotic, and fails. Histology shows widespread fibrin thrombi in the graft vasculature with neutrophil infiltration. Read the command. Which type of rejection? The rejection types are separated almost entirely by how long they take. Hyperacute rejection occurs within minutes because the recipient already has performed antibodies against donor antigens from prior transfusion, pregnancy, or a previous transplant. Those antibodies bind graft endothelium the moment blood flows, activate complement, and produce immediate thrombosis and infarction. Nothing can be done except removing the graft, which is why cross-matching before transplantation exists to prevent it entirely. Acute rejection takes days to weeks and is T-cell mediated, showing a dense mononuclear infiltrate, and it responds to increased immunosuppression. Choice B, wrong. The correct answer is A. Graft versus host disease inverts the direction of attack and is worth distinguishing because it appears in the same question stems. Donor lymphocytes attack host tissue, classically skin, gut, and liver, producing rash, diarrhea, and jaundice. It follows bone marrow transplantation and transfusion of non-irradiated blood into immunocompromised recipients, rather than solid organ grafting. Chronic rejection, meanwhile, presents months to years later with progressive vascular narrowing and fibrosis and is largely irreversible. If you see a graft failing within minutes leads to think preformed antibodies and hyperacute rejection. Which vaccine must be withheld? A 5-month-old boy has recurrent thrush, chronic diarrhea, and failure to thrive. Absolute lymphocyte count is very low and the thymic shadow is absent. Before the diagnosis is established, he is scheduled for routine immunizations. Read the command. Which vaccine must be withheld? Vaccines divide into two classes, and only one of them can cause disease in this child. The live-attenuated vaccines contain replicating organisms weakened to be harmless in an immunocompetent host. In a child with a severe combined immunodeficiency, there is no functional cellular immunity to contain that replication, so the vaccine strain can disseminate and cause fatal infection. Of the vaccines listed, Rotavirus is the live one, and it is contraindicated. The others are inactivated, subunit, toxoid, or conjugate preparations containing nothing that can replicate, so they are safe, though they may fail to generate protection. The correct answer is D. Knowing which vaccines are live answers a family of questions, since the same list governs pregnancy and immunosuppressive therapy. The trade-off is worth understanding. Live vaccines generate stronger and more durable immunity because they mimic real infection, which is exactly why they are preferred in healthy hosts and forbidden here. Absent thymic shadow with profound lymphopenia in an infant with thrush and diarrhea is the classic severe combined immunodeficiency presentation, and it is a pediatric emergency requiring isolation and transplantation. If you see immunodeficiency or pregnancy plus a vaccine, leads to check whether the vaccine is live. Which molecular defect is present? A 4-year-old boy has recurrent sinopulmonary infections and pneumocystis pneumonia. Immunoglobulin studies show markedly elevated IgM with very low IgG, IgA, and IgE. B-cell and T-cell numbers are normal. Read the command. The molecular defect. One antibody class is high while all the others are low, and that pattern points to a single failed step. IgM is the antibody a B-cell makes by default. Converting to IgG, IgA, or Eg requires class switching, and class switching requires a helper T-cell to engage the B-cell through CD40 ligand, binding CD40. When CD40 ligand is defective, hyper-IgM syndrome, usually X-linked, B-cells produce IgM normally but can never switch, so IgM accumulates while the other isotypes stay low. Cell numbers are normal because the defect is in signaling rather than in development, which distinguishes it from choice A, where B cells are absent and ALL immunoglobulins are low. The correct answer is E. The opportunistic infections are the detail that often surprises, and they follow from the same molecule. CD40 ligand also activates macrophages, so its loss impairs cell-mediated defense and permits PNE pneumocystis and cryptosporidium infection pathogens one would otherwise associate with T-cell deficiency. Choice D produces the commonest primary immunodeficiency of all, usually asymptomatic, with a characteristic risk of anaphylaxis to blood products containing IgA. If you see high IgM with low everything else, leads to think a class switching defect. Which assignment of defects is correct? 4 children present with recurrent infection. Child 1, encapsulated bacteria after 6 months of age. Child 2, recurrent Neisseria meningitis. Child 3, disseminated candidiasis and pneumocystis. Child 4, delayed umbilical cord separation with no pus at infection sites. Read the command. Which assignment is correct? Each arm of the immune system fails against a characteristic class of organism, and the pattern names the arm. Each compartment has a signature. BCEL, an antibody deficiency, permits encapsulated bacteria, pneumococcus, haemophilus, meningococcus, and becomes apparent after 6 months when maternal IgG wanes. Terminal complement deficiency, C5 through C9, permits recurrent Neisseria infections specifically because the membrane attack complex is required to lyse that organism. TCELL deficiency permits viral, fungal, and opportunistic infections such as Candida and pneumocystis. PHA-CoSI-E. Adhesion defects produce infections with no PUS and delayed umbilical cord separation because neutrophils cannot leave the vessel. The correct answer is A. Asplenia deserves a place beside the B-cell group because it produces the same vulnerability by a different route, without splenic macrophages and marginal zone B cells. Opsonized encapsulated organisms are not cleared, so these patients need vaccination against pneumococcus, haemophilus, and meningococcus, and Howell-Jolly bodies on the blood film reveal the absent spleen. Rating the organism before the immunology is the fastest route through any of these stems. If you see recurrent infection leads to, let the organism tell you which arm has failed. Which organism is most likely, and what is the underlying vulnerability? A 24-year-old man with sickle cell disease develops rapidly progressive fever, hypotension, and purpura. Blood film shows Howell-Jolly bodies. Read the command, the organism, and the vulnerability. One blood film finding announces the missing organ. Howell-Jolly bodies are nuclear remnants inside red cells that a functioning spleen would normally pit out. Their presence means the spleen is absent or non-functional. In sickle cell disease, repeated infarction destroys the spleen during childhood, producing functional asplenia. The spleen is essential for clearing opsonized encapsulated organisms, so these patients are at high risk of overwhelming infection with streptococcus, P. pneumonia, E above all, and also Haemophilus influenzae type B and Neisseria meningitis. Choices A, B, D, and E name organisms whose control does not depend on splenic function. The correct answer is C. Sickle cell disease carries a second organism association that is examined nearly as often and should be held alongside this one, Salmonella osteomyelitis, which is far more common in these patients than in the general population, where Staphylococcus aureus dominates. The preventive strategy for asplenia is straightforward and testable. Vaccinate against all 3 encapsulated organisms and give penicillin prophylaxis to young children with sickle cell disease. If you see how Jolly bodies leads to think asplenia and encapsulated organisms. Which classification is correct? 2 bacterial products are compared. Product 1 is a secreted protein, highly antigenic, destroyed by heat, and can be converted to a toxoid vaccine. Product 2 is a structural lipopolysaccharide, wholly antigenic, heat stable, and released mainly on bacterial lysis. Read the command, which classification is correct. Exotoxin and endotoxin differ on every axis, and the toxoid property is decisive. Exotoxins are secret proteins produced by both gram-positive and gram-negative organisms. Being proteins, they are highly antigenic, destroyed by Hedi, and can be chemically inactivated into toxoids for vaccination, which is exactly how tetanus and diphtheria immunization works. Endotoxin is the lipopolysaccharide of the gram-negative outer membrane, structural rather than secreted, heat-stable, poorly antigenic, and impossible to convert into a toxoid. The toxoid property alone identifies product 1 as an exotoxin, making choice A an inversion. The correct answer is B. The clinical corollary is that exotoxins produce septic syndromes while endotoxin produces one general one, which is why exotoxin questions name a disease and endotoxin questions describe shock. Tetanospasmin blocks inhibitory neurotransmitter release causing spastic paralysis. Botulinum toxin blocks acetylcholine release causing flaccid paralysis. Diphtheria and Pseudomonas exotoxin question. Endotoxin, by contrast, always produces the same picture of fever, hypotension, and disseminated intravascular coagulation. If you see, a toxin question leads to ask whether it is a secreted protein or part of the cell wall. Which empiric regimen is most appropriate? A 33-year-old woman at 30 weeks of gestation has fever, neck stiffness, and photophobia. Cerebrospinal fluid shows 100 neutrophils, low glucose, and high protein. Read the command, the empiric regimen. Bacterial meningitis coverage is standard, and one patient group requires an addition. Standard empiric therapy for bacterial meningitis in a non-pregnant adult is vancomycin plus CEF triaxone covering Streptococcus pneumoniae, including resistant strains, and Neisseria meningitis. Pregnancy, age over 50, and immunocompromised add a further organism, Listeria monocompromised tytogenes, which is intrinsically resistant to cephalosporins and requires ampicillin. Omitting ampicillin in the pregnant patient leaves the most characteristic organism of that group entirely untreated, which is why choice A, correct for a young non-pregnant adult, is wrong here. The correct answer is D. Listeria has features that recur across the exam and explain why it is singled out. It is a gram-positive rod with tumbling motility. It grows at refrigerated temperatures. It is acquired from unpasteurized dairy and deli meats, and it uses actin rockets for intracellular spread. In pregnancy, it also causes chorioamnionitis and neonatal granulomatosis infantiseptica. Adjunctive dexamethasone reduces neurological sequelae in pneumococcal meningitis and should be given with or just before the first antibiotic dose. If you see meningitis in pregnancy or over 50 leads to add ampicillin for listeria, which statement is correct? A 7-year-old girl develops bloody diarrhea without fever after eating undercooked ground beef. Stool culture on sorbitol. McConkey agar shows non-sorbitol fermenting colonies. Her physician considers antibiotics. Read the command. Which statement is correct? This organism is defined as much by how it must not be treated as by what it is. Enterohemorrhagic Escherichia coli 0157H7 produces Esch-IgA-like toxin, which inactivates the 6DS ribosomal subunit and damages endothelium. Two features are distinctive: bloody diarrhea without fever and failure to ferment sorbitol on sorbitol, McConkey agar, which is how laboratories screen for it. The critical management point is that antibiotics are avoided. Killing the organism releases more toxin, increases the risk of hemolytic uremic syndrome, so choice B recommends the opposite of correct care. Antimotility agents are avoided for the same reason. The correct answer is A. The absence of fever is a genuine discriminator rather than a throwaway detail, and it makes choice C exactly backwards: most invasive bacterial dysenteries. Shigella, Campylobacter, Salmonella produce fever, whereas enterohemorrhagic E. coli typically does not because the damage is toxin-mediated rather than invasive. Choice E describes a preformed toxin illness such as Staphylococcus aureus or Bacillus cereus, food poisoning, which causes vomiting within hours rather than bloody diarrhea after days. If you see, bloody diarrhea after ground beef without fever leads to withhold antibiotics. Which pairing is correct? Two patients have complement-related disease. Patient 1 has episodic non-pruritic facial and laryngeal swelling with low C4 and normal C3. Patient 2 has dark morning urine, unexplained thrombosis, and flow cytometry showing absent CD55 and CD59. Read the command. Which pairing is correct? Two diseases of complement regulation, each losing a different break. C1 ion inhibitor deficiency causes hereditary angioedema. Without it, the classical pathway and the kallikrein system run unchecked, generating bradykinin, so the swelling is non-pruritic and does not respond to antihistamines or adrenaline, unlike allergic angioedema. Consumption of C4 lowers it while C3 remains normal, a useful screening pattern. Paroxysmal nocturnal hemoglobinuria is a pico mutation causing loss of the GPI anchor that holds CD55 and CD59 on red cells, leaving them undefended against complement, producing intravascular hemolysis and, characteristically, thrombosis. Choice A reverses the two. The correct answer is B. Two treatment implications follow directly from the mechanisms. Because hereditary angioedema is bradykinin-mediated rather than histamine-mediated, adrenaline and antihistamines are ineffective, and ACE inhibitors are contraindicated since they raise bradykinin further. In paroxysmal nocturnal hemoglobinuria, EC-ulizumab blocks C5 and prevents both hemolysis and thrombosis, but by blocking terminal complement, it creates the very deficiency described earlier in this block, so patients must be vaccinated against Neisseria before starting it. If you see a complement regulator missing, leads to ask which break was lost and what runs unchecked. Which pairing is correct? Two patients have autoimmune hemolysis. Patient 1 has chronic anemia with spherocytes, a positive direct antiglobulin test for IgG, and underlying lupus. Patient 2 has acrocyanosis in cold weather and a positive test for C3 only, following a mycoplasma infection. Read the command. Which pairing is correct? Two autoimmune hemolytic anemias differ by antibody class, by temperature, and by what the Coombs test detects. Warm autoimmune hemolytic anemia is mediated by IgG, which binds red cells at body temperature. The coated cells are partially removed by splenic macrophages, producing spherocytes and extravascular hemolysis. It is associated with lupus, chronic lymphocytic leukemia, and drugs such as methyldopa, and the direct antiglobulin test detects IgG. Cold agglutinin disease is mediated by IgM, which binds in cooler peripheral blood and fixes complement before eluting. So the antiglobulin test detects C3 alone. It follows mycoplasma and infectious mononucleosis, and choice A reverses the pair. The correct answer is E. Choice D names the disease that shares the spherocytes and is separated by one test. Hereditary. Spherocytosis also shows spherocytes and extravascular hemolysis, but it is a membrane protein defect rather than an antibody-mediated process, so the direct antiglobulin test is negative. Adding the osmotic fragility or eosinophil nalamide test confirms it. The treatments diverge accordingly: steroids for warm autoimmune disease, splenectomy for hereditary spherocytosis, and thermoprotection for cold agglutinin disease. If you see spherocytes with hemolysis leads to let the Coombs test decide antibody from membrane. Which organism is it? A wound culture grows gram-positive cocci in clusters. The isolate is catalase positive and coagulase positive, and it ferments mannitol on salt agar. Read the command. Which organism? The staphylococci are separated by a short sequence of bench tests, and each test eliminates a group. The algorithm runs in fixed order. Gram-positive cocci in clusters with a positive catalase are staphylococci. Streptococci are catalase negative and grow in chains, which excludes choices A and D. Among staphylococci, coagulase separates the pathogen from the commensals. Coagulase positive means staphylococcus are in use, which also ferments mannitol and produces yellow colonies on mannitol salt agar. The coagulase. Negative staphylococci are epidermidis, which colonizes prosthetic material and catheters. and saprophyticus, which causes cystitis in young women and is novobiostin resistant. The correct answer is C. Staphylococcus aureus earns its position as the most versatile pathogen in the exam because of what it produces. Protein A binds the Fc portion of IgG and blocks opsonization. TSST1 acts as a superantigen. Exfoliative toxin causes scalded skin syndrome, and preformed enterotoxin causes food poisoning with vomiting within hours. It is also the leading cause of acute endocarditis, osteomyelitis, and septic arthritis in most populations. If you see gram-positive cocci in clusters leads to run catalase, then coagulase. Which organism is it? A throat swab from a child with fever and tonsillar exudate grows gram-positive cocci in chains, showing complete clear hemolysis on blood agar. The isolate is bacitracin sensitive. Read the command. Which organism? Hemolysis pattern narrows the group, and one further test names the species. Streptococci are sorted first by hemolysis. Beta hemolysis is complete clearing of the agar, and it identifies two important species separated by bacitracin. Bacitracin sensitive is Streptococcus pyogenes. Group A, the cause of pharyngitis, scarlet fever, empatizing fasciitis. Bacitracin resistant is Streptococcus agalactiae. Group B, which colonizes the vagina and causes neonatal sepsicitis. Bacitracin resistant is Streptococcus agalactiae. Group B, which colonizes the vagintracin sensitive is insensitive is Streptococcus pyogenes. Group A. Alpha hemolysis is partial green discoloration and belongs to pneumococcus and the viridans group, so choices A and C are excluded by the complete clearing described. The correct answer is D. The alpha hemolytic pair is separated by the same style of test and completes the framework. Opitoxin sensitivity and bowel solubility identifies Streptococcus pneumoniae, while optochin resistance identifies the viridans group, which causes dental caries and subacute endocarditis on previously damaged valves. Group A, Streptococcus, is also the organism behind both post-streptococcal sequelae seen earlier in this series, rheumatic fever by molecular mimicry, and glomerulonephritis by immune complexes. If you see Streptococci leads to read the hemolysis, then apply the disc test. Which mechanism explains the difference? A 2-year-old receives a pure polysaccharide pneumococcal vaccine and mounts a poor, short-lived IgM response with no memory. The same child receives a conjugate pneumococcal vaccine and mounts a strong IgG response with durable memory. Read the command, the mechanism of the difference. The distinction between T-dependent and T-independent antigens is the whole answer. Pure polysaccharide antigens are Ti-independent. They cross-link B-cell receptors directly and elicit an IgM response, but because no T-cell is involved, there is no CD40-mediated help, therefore no CLS switching, no affinity maturation, and no memory. Young children respond especially poorly. Conjugating the polysaccharide to a protein carrier converts it into a T-dependent antigen. The B-cell internalizes the complex, presents carrier peptides on MHC class II, and recruits helper T-cells, which supply the signals for switching to IgG and for generating memory. The correct answer is E. The same principle explains the hyper-IgM syndrome seen earlier. Without CD40 ligand, even a T-dependent antigen cannot drive class switching, so the response is stuck at IgM, the identical endpoint reached here for a different reason. It also explains why conjugate vaccines transform pediatric practice, effectively eliminating Haemophilus influenzae type B meningitis in vaccinated populations, where the earlier polysaccharide product had failed in exactly the age group that needed it most. If you see poor vaccine response under age 2 leads to think T-independent antigen and no memory. Which statement about these two interventions is correct? An unvaccinated man sustains a deep contaminated wound. He is given both tetanus toxoid and tetanus immune globulin. Read the command. Which statement is correct? Passive and active immunization do opposite things on opposite timescales, which is precisely why both are given. Passive immunization supplies performed antibody, Protection is immediate, which is what an unvaccinated patient with an established contaminated wound needs, but it is short-lived. The transferred antibody decays over weeks, and it generates no memory. ACTIV, immunization with toxoid, makes the patient's own immune system respond. Protection takes 1 to 2 weeks to develop but produces lasting immunity with memory. Giving both is deliberate and complementary, covering the gap before the active response matures, so choice E is wrong. The correct answer is B. The same combined strategy appears in several post-exposure settings and is worth recognizing as a pattern rather than 3 separate facts: tetanus, rabies, and hepatitis. B. All use immune globulin plus vaccine after a high-risk exposure. Maternal IgG crossing the placenta is the natural example of passive immunity, and its decay by around 6 months is exactly why B-cell deficiencies such as Bruton agammaglobulinemia declare themselves at that age. If you see post-exposure prophylaxis leads to give borrowed antibody for now and a vaccine for later, which statement comparing the two responses is correct? A patient encounters an antigen for the first time and then again 8 months later. Read the command. Which comparison is correct? Primary and secondary responses differ in speed, isotype, and affinity, all in the same direction. The primary response has a lag of 1 to 2 weeks, while naive B cells find the antigen, proliferate, and differentiate. It is dominated by IgM of relatively LOW affinity and generates modest titers. The secondary response draws on memory B cells already selected for that antigen. Latency shortens to days. The dominant isotype is IgG through class switching. Affinity is higher through somatic hypermutation and selection in germinal centers, and the titer is far greater. Every parameter improves, which makes choices A, C, and E each wrong in a different direction. The correct answer is D. The serologic application is what makes this immediately useful at the bedside. Detecting IgM against an organism indicates ACU or recent infection, whereas IgG indicates past exposure or immunity. The basis for interpreting hepatitis, toxoplasma, rubella, and cytomegalovirus serology. The same principle explains the booster schedule of vaccines, each dose recruiting memory cells to produce a higher affinity, longer-lasting response than the one before. If you see, IgM versus IgG on serology leads to think acute infection versus past exposure. Which mechanism is responsible? A 19-year-old man develops urticaria, wheeze, hypotension, and stridor within 3 minutes of a bee sting. He has been stung before without incident. Read the command, the mechanism. Immediate systemic reactions are type 1, and the prior uneventful exposure is part of the mechanism rather than an argument against it. TYPE. A hypersensitivity requires prior sensitization. The first exposure generates antigen-specific IgE that binds FCEE, that binds Fc epsilon receptors on mast cells and basophils without causing symptoms, which is exactly why the earlier sting was uneventful. On REE exposure, the antigen, cross, links adjacent IgE molecules, triggering immediate degranulation with release of preformed histamine and tryptase, followed by newly synthesized leukotrienes and prostaglandins. The result within minutes is vasodilation, capillary leak, bronchoconstriction, and hypotension, anaphylaxis. The correct answer is A. Choice E describes the anaphylactoid reaction, which is the important lookalike, radiocontrast, vancomycin, and opioids can degranulate mast cells directly without any IEE involvement, so the reaction can occur on first exposure. Clinically, the two are indistinguishable and both are treated with intramuscular adrenaline as the first and most important intervention, but only the IgE-mediated form can be confirmed by skin testing or specific IgE assay. If you see systemic symptoms within minutes of a re-exposure leads to think IgE cross-linking and give adrenaline. Which hypersensitivity type is this? A nurse has a tuberculin skin test placed. At 48 hours, the site shows a firm indurated plaque of 14 mm. Biopsy of a similar reaction would show a mononuclear infiltrate with macrophages and CD4 lymphocytes and no antibody deposition. Read the command. Which hypersensitivity type? The timing and the absence of antibody together identify one category. TYPE hypersensitivity is the only antibody. Independent category, it is mediated entirely by TCELS. Sensitized CD4 cells recognize antigen presented by macrophages, release interferon gamma, and recruit and activate further macrophages, a process that takes 24 to 72 hours, which is why it is called delay AT. The clinical signature is ion duration rather than the wheel and flare of an immediate reaction. Because no antibody is involved, type 4 cannot be transferred with serum, only with cells, which is a classic experimental distinction. The correct answer is C. The tuberculin test is also a lesson in interpreting a result against pretest probability rather than against a single number. Since the induration threshold for a positive result varies by risk group, 5 mm in infection or recent contacts, 10 mm in healthcare workers and immigrants from endemic areas, and 50 million people with no risk factors. Interferon gamma release assays measure the same cellular response in vitro and avoid false positives from prior BCG vaccination. If you see a reaction peaking at 48 hours with induration leads to think type 4 and T cells. Which statement about his condition is correct? A 28-year-old immigrant has a positive interferon gamma release assay, a normal chest radiograph, no cough, no fever, and no weight loss. 3 sputum samples are smear negative. Read the command. Which statement is correct? Latent and active tuberculosis differ in symptoms, imaging, contagiousness, and treatment. A positive immunologic test with a normal chest radiograph and no symptoms defines LAT tuberculosis infection. Viable organisms are contained within granulomas. The patient is not contagious, and there is a lifetime risk of reactivation of roughly 5 to 10%, much higher with HIV infection, tumor necrosis factor inhibitors, or immunosuppression. Treating latent infection with isoniazid for a period, or rifampin, substantially reduces that risk. ACTI disease, which shows symptoms, radiographic changes, and positive smears, which excludes choice A. The correct answer is E. Choice D is excluded by the choice of test, which is precisely why interferon gamma release assays were developed. Unlike the tuberculin skin test, they use antigens absent from BCG, so prior vaccination does not cause a false positive. Note also the reactivation pattern, which appears constantly in imaging questions. Primary infection affects the lower lobes and hilar nodes, whereas REA stivation favors the apical and posterior segments of the upper lobes, where oxygen tension is highest. If you see a positive tuberculin test with a normal film leads to treat the latent infection. Which stage of infection does the rash represent? A 30-year-old man has a painless indurated genital ulcer with a clean base and non-tender inguinal nodes. It resolves without treatment. 9 weeks later, he develops a diffuse maculopapular rash involving the palms and soleus. Read the command. Which stage the rash represents? Syphilis is staged by time and by the lesion, and each stage has one signature finding. Primary syphilis is the painless indurated syncytial with a clean base, appearing around 3 weeks after exposure and healing spontaneously, which is why patients often present later. Secondary syphilis follows weeks to months later as the organism disseminates, producing a maculopapular rash that characteristically involves the pale mass and soleus, along with condylomata lata, mucus patches, and generalized lymphadenopathy. Tertiary syphilis appears years later with gummas, aortitis of the ascending aorta, and neurosyphilis, so choice B is excluded by the interval. The correct answer is D. The painless quality of the chancre is itself a discriminator worth holding, since choice C names its main competitor, chancroid, caused by Haemophilus ducreyi, produces a painful ulcer with a ragged base and tender suppurative nodes. A short mnemonic keeps them apart. Ducreyi with chancroid. Note also the J6-Harexheimer reaction after treatment, a fever, and rigors from released If you see a rash on the palms and soles after a painless ulcer leads to think secondary syphilis. What is the best next step? A man presents 10 days after a high-risk exposure with fever, sore throat, and lymphadenopathy. A fourth-generation HIV antigen antibody immunoassay is negative. Read the command, the best next step. A negative test early after exposure means something different from a negative test later, and the window period is the reason. Antibody-based tests require seroconversion, which takes weeks, so a negative result within the window period cannot exclude infection, and choice A would be dangerously wrong. Viral RNA, by contrast, is detectable within about 1 to 2 weeks of infection, well before antibodies appear. In the patient with a high-risk exposure and in acute retroviral syndrome of fever, pharyngitis, and lymphadenopathy, HIV RNA by PCR is the test that establishes the diagnosis at this point, and it also identifies the phase of highest viremia and greatest transmissibility. The correct answer is C. Choice E names a test with a real role that is not diagnostic, and the distinction is examined often, the CD4 count stages. The infection and predicts which opportunistic infections threaten the patient, while the viral load measures disease activity in response to therapy. Fourth-generation assays shorten the window by detecting P24 antigen alongside antibody, but even they can be negative in the first days, which is exactly the situation described here. If you see a negative HIV antibody test soon after exposure leads to order the RNA, not reassurance. Which organism is most likely? A man with untreated HIV and a CD4 count of 38 cells, or micro-L, develops progressive visual blurring with painless vision loss. Fundoscopy shows hemorrhages and fluffy white perivascular exudates. Read the command, the most likely organism. Opportunistic infections in HIV appear in a predictable order as the CD4 count falls, and the organ involved narrows it further. The CD4 count acts as a clock. Below 20, the risk is pneumocystis pneumonia. Below 100, Toxoplasma encephalitis and Cryptococcus. Below 50, cytomegalovirus disease and disseminated Mycobacterium avium complex. At a CD4 of 38 with retinitis specifically, cytomegalovirus is the answer. Its retinitis produces the characteristic pizza pie appearance of hemorrhage mixed with fluffy exudate, and it causes painless progressive visual loss that becomes irreversible without treatment. Choices A, C, and D belong to higher CD4 thresholds and to different organs. The correct answer is B. Using the count to generate a differential before considering the organ is the fastest route through these questions, and it also drives prophylaxis decisions. Trimethoprim sulfamethoxazoline below 200 for pneumocystis, which also covers toxoplasma, and azithromycin below 50 for Mycobacterium avium complex. Note the neurological pairing at the same threshold. Toxoplasmosis produces multiple RI-ing enhancing lesions, whereas primary CNS lymphoma classically produces a single one, and Epstein-Barr virus in the cerebrospinal fluid supports the latter. If you see an opportunistic infection in HIV leads to read the CD4 count before the organ. Which organism is present and what additional intervention is needed? A man with advanced HIV has 2 weeks of headache and low-grade fever. Lumbar puncture shows an opening pressure of 38 centimeters of water with a lymphocytic piocytosis. India ink preparation shows encapsulated budding yeast. Read the command, the organism, and the extra intervention. The stain names the fungus, and 1 number in the stem changes management. TR ripito cus kisneofumans is an encapsulated yeast acquired from pigeon droppings and soil, and it is the leading cause of fungal meningitis in advanced HIV. India Inc. outlines the polysaccharide capsule as a clear halo, and the cryptococcal antigen test is more sensitive. The detail that changes management is the opening pressure. Cryptococcal meningitis raises intracranial pressure dramatically, and that pressure, not the fungal burden alone, causes visual loss and death. Serial, therapeutic, lumbar punctures to remove cerebrospinal fluid are required alongside antifungal therapy. The correct answer is A. Recognizing that the pressure itself is the emergency is what separates a correct answer from a nearly correct one here, since choice B and choice C both name plausible antifungal strategies while ignoring the number that matters. The antifungal regimen is also worth knowing in its sequence: induction with amphotericin B plus fluoxetosine, then consolidation and maintenance with fluconazole until immune reconstitution. If you see cryptococcal meningitis, leads to read the opening pressure and drain it. Which species is most likely, and why does it matter? A traveler returns from West Africa with cyclical fevers. Blood smear shows ring forms with multiple parasites per erythrocyte, banana-shaped gametocytes, and a parasitemia of 8%. He becomes confused. Read the command, the species, and why it matters. Malaria species differ in severity and in whether a dormant liver stage must be treated. Plasmodium falciparum is identified on the smear by emultiple ring forms within a single erythrocyte, banana-shaped gametocytes, and high parasitemia because unlike the other species, it invades red cells of AL ages rather than only young or old ones. That capacity for overwhelming parasitemia, combined with cytoadherence of infected cells to cerebral microvasculature, produces cerebral malaria, severe anemia, and death. It is a medical emergency requiring intravenous artesunate. Choices A and C name the relaxing species, whose distinguishing feature is different. The correct answer is B. The relapsing species matter for a different reason and are commonly paired with this one in questions. VI vax an oval-form dormant HY pinozoites in hepatocytes, so eradicating the blood stage alone permits relapse weeks or months later. Primaquine is added to clear them. And G6PD status must be checked first because primaquine causes hemolysis and deficiency. Sickle cell trait, and to a lesser extent thalassemia and G6PD deficiency, confer partial protection against falciparum, which is why these traits persist in endemic regions. If you see hyperparasitemia with banana gametocytes leads to think falciparum and treat it as an emergency. Which stage of infection does the cardiac finding represent? A hiker in Connecticut develops an expanding annular rash with central clearing 3 weeks after a tick bite. 2 months later, untreated, he develops a facial droop and intermittent complete heart block. Read the command, which stage the cardiac finding represents. Lyme disease has 3 stages, and each has its own set of manifestations. Lyme disease, caused by Borrelia burgdorferi and transmitted by the Ixodes tick, progresses in 3 stages. EARly localized disease is the expanding target-shaped rash, erythema migrans, appearing days to a month after the bite. ARE disseminated disease follows over weeks to months, and its hallmarks are neurological and cardiac, Bell palsy, which is often bilateral, meningitis, and AV block that can fluctuate to complete heart block. Late disease appears months to years later as a migratory monoarticular arthritis, typically of the knee, which excludes choice E. The correct answer is D. Bilateral facial palsy is a finding with a very short differential, and Lyme disease sits at the top of it, alongside sarcoidosis and Guillain-Barré syndrome. Treatment follows the stage: doxycycline for early localized disease, and intravenous EF triaxone for cardiac or central nervous system involvement. In children under 8 and in pregnancy, amoxicillin replaces doxycycline to avoid dental staining. If you see facial palsy or heart block after a tick bite, leads to think early disseminated Lyme disease. What is the appropriate management? A previously unvaccinated man is bitten by a bat found in his bedroom. The bat escapes and cannot be tested. He has no wound infection and is otherwise well. Read the command, the appropriate management. Rabies is one of the few infections where waiting for symptoms is equivalent to accepting death. Rabies is essentially 100% fatal once symptoms appear, so post-exposure prophylaxis must be given before any clinical illness, which makes choice A. Untenable. In a previously unvaccinated person, prophylaxis has TWO components: RABs, immune globulin infiltrated around the wound for immediate passive protection during the weeks before antibodies develop, plus a vaccine series for active immunity. Bats are a major reservoir in many countries, and because their bites can be small and unnoticed, prophylaxis is recommended even for possible exposures such as waking with a bat in the room. The correct answer is E. The exception is worth knowing precisely because it is the same passive plus active logic applied to a different starting point. A person who has been previously vaccinated already has memory cells, so they receive a vaccine booster alone and no immune globulin. The virus travels retrogradely along peripheral nerves to the central nervous system, which explains the long and variable incubation period and why prophylaxis remains effective even days after the bite. If you see a possible rabies exposure in an unvaccinated person, needs to give both globulin and vaccine. Which interpretation is correct? A patient's hepatitis B serology shows HBsAg negative, anti-HB positive, anti-HBC positive, Ig. Read the command. Which interpretation is correct? Hepatitis B serology is a three-marker pattern, and the core antibody is what distinguishes vaccination from infection. Three markers answer nearly every hepatitis B question. HBsAg indicates ACTIV infection, acute or chronic. Its absence here excludes choices A and D. Anti-HBs indicates IM immunity, whether from vaccination or from resolved infection. Anti-HBC is the discriminator. The core antigen is not present in the vaccine, so core antigen is not present in the vaccine. So core antibody appears only after natural, only after natural infection. Surface antibody positive with core antibody positive therefore means immunity from resolved natural infection, whereas vaccination gives surface antibody alone. The correct answer is C. The window period is the pattern that catches people out and is worth recognizing. During the interval when surface antigen has cleared, but surface antibody has not yet appeared, the only positive marker is anti-HBC IgM. So a patient can be infected and recently infectious while both of the commonly checked markers are negative. HBA, separately, indicates active viral replication and high infectivity rather than a stage of immunity. If you see hepatitis B serology leads to read the core antibody to separate vaccination from infection. Which mechanisms are these, and what does each cause? Each year, influenza vaccines are reformulated because of small accumulating mutations in hemagglutinin. Separately, a novel strain occasionally emerges when two influenza viruses co-infect one host and exchange whole genome segments. Read the command. Which mechanisms and what each causes? Two kinds of genetic change in one virus with very different epidemiological consequences. The genic drift is the gradual accumulation of point mutations in hemagglutinin and neuraminidase. Existing immunity becomes progressively less effective, producing the seasonal epidemics that require annual reformulation of the vaccine. Antigenic shift is reassortment. Influenza A has a segmented genome, so when two strains co-infect the same cell, classically in a pig or bird host, whole segments are swapped, generating a novel subtype against which the population has NO immunity. That is what produces pandemics. Choice B reverses the consequences. The correct answer is A. Only influenza A undergoes shift, and the reason is worth understanding rather than memorizing. Shift requires two different strains to meet inside one cell, which requires a host susceptible to more than one strain. In influenza, A infects birds, pigs, and humans, whereas influenza B is essentially restricted to humans. The segmented genome is the structural prerequisite, which is why reassortment is possible for influenza and not for viruses with a single continuous genome. If you see a novel influenza subtype with no population immunity, leads to think shift and reassortment. Which statement about this virus is correct? A virus is found to have a single-stranded, positive sense RNA genome that can be translated directly by host ribosomes on entering the cytoplasm. Read the command. Which statement is correct? The sense of an RNA genome determines what the virus must bring with it and whether the genome alone can start an infection. A positive. Since RNA genome is messenger RNA. On entering the cytoplasm, it is translated directly by host ribosomes into viral proteins, including the RNA-dependent RNA polymerase needed for replication, so the virus does not need to package that enzyme, and the naked genome introduced into a cell is by itself infectious. Negative. Since RNA is the complement of messenger RNA and cannot be read by ribosomes, so those viruses must carry their own RNA-dependent RNA polymerase in the virion, and their naked genome is not infectious. Choice A states the negative sense requirement. The correct answer is C. Retroviruses form the third category and are what choice B describes. They are positive sense but must be reversed, transcribed into DNA before anything is expressed, so they carry reverse transcriptase, and their naked genome is not infectious either. A useful organizing question for any virus stem is simply what the virion must bring along. Negative sense RNA viruses bring a polymerase, retroviruses bring reverse transcriptase, and positive sense RNA viruses bring nothing but their genome. If you see a positive sense RNA virus leads to its genome alone can start the infection. Which agent is responsible? A 62-year-old man develops rapidly progressive dementia over 4 months with startle myoclonus and ataxia. Electroencephalography shows periodic sharp wave complexes, and cerebrospinal fluid 14-33 protein is elevated. Brain biopsy will show spongiform change without inflammation. Read the command. Which agent? Rapidly progressive dementia has a short differential, and one cause contains no nucleic acid at all. Prion disease is caused by pre-P scrapie, a misfolded form of a normal host protein that contains endonucleic acid. It propagates by inducing normally folded pre-P to adopt the same beta-pleated sheet conformation, producing spongiform vacuolation of gray matter without any inflammatory infiltrate, because there is no foreign antigen for the immune system to recognize. CREUZ-FIL-T, Jacobi disease, presents exactly as described, rapidly progressive dementia over months with startle myoclonus, periodic sharp waves on electroencephalography, and elevated 14-33 protein. The correct answer is D. The absence of inflammation is the histologic signature and reflects the mechanism directly, distinguishing prion disease from the viral encephalitis in the other choices. Herpes simplex produces hemorrhagic temporal lobe necrosis with intranuclear inclusions, and JC virus produces progressive multifocal leukoencephalopathy in immunosuppressed patients with demyelination. The practical hazard is that prions resist standard autoclaving, formalin, and ultraviolet light, which is why contaminated neurosurgical instruments have transmitted the disease. If you see rapid dementia with myoclonus and no inflammation leads to think prion disease. Which assignment is correct? 3 clostridial diseases are compared. Disease 1 follows antibiotic use with pseudomembranous colitis. Disease 2 follows ingestion of home canned food with descending flaccid paralysis. Disease 3 follows a puncture wound with lockjaw and opisthotonus. Read the command. Which assignment is correct? 4 clostridia, 4 syndromes, and 2 of them produce opposite kinds of paralysis. Clostridial oides difficile overgrows after antibiotics disrupt colony flora, and its toxins A and B produce PSC domembranous colitis. Clostridium botulinum produces a preformed toxin in improperly canned food that blocks acetylcholine release at the neuromuscular junction, causing descending flaccid paralysis beginning with cranial nerves. Clostridium tetani enters through a puncture wound, and its toxin blocks release of the I inhibitory neurotransmitters glycine and GABA in the spinal cord, producing spastic paralysis with trismus and opisthotonus. The order is difficile botulinum tetani. The correct answer is B. The 2 neurotoxins are worth holding as a matched pair because their mechanisms are exact opposites. Botulinum removes E-excitation at the muscle, giving flaccid paralysis. Tetanus removes ion inhibition in the cord, getting spasticity. Both are among the most potent toxins known, and both act by cleaving snare proteins, just in different neurons. The 4th member, Clostridium perfringens, produces alpha-toxin, a lecithinase, causing gas gangrene and myonecrosis. If you see A Clostridial syndrome leads to decide whether the toxin removed excitation or inhibition. What is the most important next step? A 55-year-old diabetic man develops severe pain in the thigh, out of proportion to the modest skin findings, followed within hours by dusky discoloration, bullae, and crepitus. He is febrile and hypotensive. Read the command, the most important next step. 2 soft tissue infections look similar early, and only one of them is a surgical emergency. Mecroticine fasciitis spreads along fascial planes faster than the overlying skin can reflect it, which is why pain out of proportion to the visible findings is the cardinal early sign. Crepitus indicates gas in the tissues. Bullae and dusky discoloration indicate necrosis, and systemic toxicity follows quickly. Mortality rises with every hour of delay, so the answer is immediate. Surgical exploration and debridement with broad-spectrum antibiotics, not further imaging, which delays definitive treatment, and certainly not observation or outpatient management. The correct answer is A. Distinguishing this from ordinary C. eulalitis is the clinical skill being tested, and the discriminators are the ones named in the stem. Cellulitis is superficial, progresses over days rather than hours, does not produce crepitus or bullae, and responds to antibiotics alone. Choice D is the most tempting wrong answer precisely because imaging feels responsible. But in a patient with this constellation, the diagnosis is clinical and the operating theater is the diagnostic test. If you see, bang, out of proportion with crepitus leads to operate, do not image. Which organism is most characteristically associated with her underlying disease? A 9-year-old girl with sickle cell disease develops fever and severe pain in the humerus. Imaging confirms osteomyelitis and bone culture is pending. Read the command, which organism is characteristically associated? Osteomyelitis has a default organism and several host-specific exceptions. Staphylococcus aureus is the commonest cause of osteomyelitis in essentially every population, including patients with sickle cell disease in absolute terms. But the association the exam tests is the distinctive one. Salmonella osteomyelitis occurs far more often in sickle cell disease than in anyone else, and the question asks specifically what is characteristically associated with her underlying disease. Bowel microinfarction from sickling is thought to permit bacterial translocation, and functional asplenia impairs clearance of this encapsulated organism. The correct answer is E. This family of host organism pairings recurs throughout the exam and rewards learning as a set rather than individually. A nail puncture through a rubber-soled shoe points to PSEU dominus, a prosthetic joint to coagulase, negative staphylococci, indolent vertebral disease to tuberculosis, and a sexually active young adult with polyarthralgia to Neisseria gonorrhea. Reading the host before the site narrows the answer faster than reading the site alone. If you see osteomyelitis leads to identify the host before naming the organism. What is the most appropriate immediate action? A 48-year-old woman receiving chemotherapy has a temperature of 38.6 degrees. C. Absolute neutrophil count is 240 or micro-L. She has no localizing symptoms and her chest radiograph is normal. Read the command, the immediate action. A fever in a neutropenic patient is an emergency even when everything else looks normal. Febrile neutropenia is defined by a single temperature of 38.3 degrees C or a sustained 38.0 degrees C with an absolute neutrophil count below 500. The absence of localizing findings is expected rather than reassuring. Without neutrophils, there is no pus, no infiltrate, and often no physical sign, so the usual clues to a source are missing. Mortality without prompt treatment is high, so empiric broad-spectrum antibiotics with N-tip pseudomonal coverage, cefepime, piperacillin, tazobactam, or carbapenemol must be started immediately after cultures are drawn, not after they return. The correct answer is B. 2 refinements follow the initial regimen and are commonly examined. Vancomycin is added when a catheter-related or skin infection is suspected, or when the patient is unstable, and empiric antifungal therapy is added when fever persists beyond 4 to 7 days despite antibacterials, since invasive candidiasis and aspergillosis become likely. Choice A embodies the error. The question targets waiting for microbiological confirmation in a patient who may deteriorate within hours. If you see fever with a neutrophil count under 500 leads to culture and treat in the same hour. Which naming is correct? 3 complement activation pathways converge on C3. Pathway 1 is triggered by antigen antibody complexes binding C1. Pathway 2 is triggered by microbial surfaces without antibody. Pathway 3 is triggered by mannose residues on pathogen surfaces. Read the command. Which naming is correct? 3 pathways, 3 triggers, 1 convergence point. The classical pathway is triggered by IgG or IgM bound to antigen, which recruits C1. It is called classical because it was discovered first and it depends on antibody. The A alternative pathway is triggered directly by microbial surfaces through spontaneous C3 hydrolysis, requiring no antibody, which makes it part of innate immunity and available immediately. The lectin pathway is triggered by mannose-binding lectin recognizing mannose residues on pathogen surfaces. All 3 converge on C3 convertase and proceed to the membrane attack complex. The correct answer is A. The functions of the fragments matter more than the pathway names in most questions, and they are worth attaching here. C3b obeascinases for phagocytosis. C3a and C4a are anaphylatoxins causing mast cell degranulation. C4a is also the major chemotactic factor for neutrophils, and C5 through C9 assemble the membrane attack complex that lyses Neisseria. The mnemonic for the classical trigger is that IgG and IgM make classic cars. If you see a complement question leads to name the trigger, then the fragment doing the work. What is the appropriate advice? A woman at 12 weeks of gestation is found to be non-immune to varicella and to rubella and requests vaccination. Read the command, the appropriate advice. Both vaccines belong to the same class, and that class is contraindicated in pregnancy. Varicella and measles, mumps, rubella are both live attenuated vaccines, and live vaccines are contraindicated in pregnancy because of the theoretical risk that the attenuated organism could infect the fetus. Both should therefore be deferred until after delivery, and the postpartum period is in fact the standard time to give them. They are safe during breastfeeding, and vaccinating the mother protects her in future pregnancies. Choices B, C, and E each administer at least 1 live vaccine during gestation. The correct answer is D. Knowing which vaccines are actively recommended in pregnancy is the other half of this topic and is examined just as often. Inactivated influenza in any trimester and T-day between 27 and 36 weeks specifically, so that maternal antibody crosses the placenta and protects the newborn against pertussis before their own immunizations begin. That is passive immunity used deliberately. The same principle seen earlier with immune globulin. If you see vaccination in pregnancy leads to defer the live ones, give inactivated influenza and Tdap. Which naming is correct? 2 cytokines are compared. Cytokine 1 is released by virally infected cells and induces neighboring cells to degrade viral RNA and halt protein synthesis. Cytokine 2 is released by natural killer cells in H1 lymphocytes and is the principal activator of macrophages. Read the command. Which naming is correct? The interferons share a name and do quite different jobs. I-interferon. Alpha and beta are the type. I-interferons, released by virally infected cells to warn neighbors. They induce an antiviral state in which ribonuclease L degrades viral RNA and protein kinase R halts translation, limiting spread before adaptive immunity arrives. I-interferon. Gamma is the Ty2 interferon produced by natural killer cells and H1 lymphocytes, and its principal role is activating macrophages to kill ingested organisms and to maintain granulomas. Choice B reverses the 2. The correct answer is C. The clinical uses follow the biology and make the bearing easier to retain. Interferon alpha was the mainstay of hepatitis B and C therapy, while interferon gamma is given in chronic granulomatous disease to boost macrophage killing. Its role in granuloma maintenance also explains a major drug hazard seen in the next question. Anything that interrupts this axis, including tumor necrosis factor blockade, permits mycobacterial reactivation. If you see interferon in a stem leads to decide whether it is fighting a virus or arming a macrophage. Which naming is correct? A helper T cell subset secretes interleukin 2 and interferon gamma drives macrophage activation and cell-mediated immunity and is inhibited by interleukin 10. A second subset secretes interleukin 4, 5, and dopamine 13, drives IgE class switching and eosinophils, and is inhibited by interferon gamma. Read the command, which naming is correct. Two helper subsets that inhibit each other, each with its own cytokines and its own kind of immunity. Lead cells secrete interleukin 2 and interferon gamma activate macrophages and cytotoxic T cells and drive CE-toxic mediated immunity against intracellular organisms. They are differentiated by interleukin 12 and inhibited by interleukin 10 and interleukin 4. D2 cells secrete interleukin 4, 5, and 13, drive HEE class switching, eosinophil recruitment 4, 5, and 13, drive allergic disease. They are differentiated by interleukin 4 and inhibited by interferon gamma. The reciprocal inhibition is the elegant part, and choice A inverts the pair. The correct answer is E. The reciprocal relationship explains disease patterns that would otherwise look arbitrary, which is why it is worth holding as a mechanism. In lepromatous leprosy, a ET2 dominant response fails to control the mycobacterium and organisms proliferate, whereas in tuberculoid leprosy, a ETH1 dominant response contains it within granulomas with few organisms. Choice. D names regulatory T cells, which express FOXP3 and secrete interleukin 10 and TGF-beta to suppress both arms, and whose failure causes the IPEX syndrome. If you see a cytokine profile leads to let interferon gamma versus interleukin 4 assign the subset. Why must this be addressed before starting the drug? A patient with rheumatoid arthritis is about to start infliximab. He is asymptomatic but has a positive interferon gamma release assay with a normal chest radiograph. Read the command, why it must be addressed. The mechanism of the drug and the mechanism of granuloma maintenance are the same pathway. Latent tuberculosis is contained inside granulomas, and granuloma integrity depends on tumor necrosis factor, alpha, together with interferon gamma activated macrophages. Blocking tumor necrosis factor with infliximab or a similar agent causes granulomas to destabilize, releasing viable organisms and permitting reactivation, often with disseminated or extrapulmonary disease. This is why every patient must be screened for latent tuberculosis before starting a tumor necrosis factor inhibitor and treated for it first. The correct answer is B. The same reasoning explains the other warnings attached to this drug class and turns a list of precautions into one principle. Interrupting a containment mechanism releases whatever was being contained, so hepatitis B reactivation and invasive fungal infection belong to the same category of risk. It also connects directly to the previous question. Interferon gamma and tumor necrosis factor are the two arms of granuloma maintenance, and a defect in either, whether genetic or pharmacologic, produces mycobacterial disease. If you see a tumor necrosis factor inhibitor, at least to screen for latent tuberculosis first. Which two antibodies are these? A 31-year-old woman has Mahler rash, arthritis, and proteinuria. Antinuclear antibody is positive at high titer. Two additional antibodies are found. One is highly specific for her disease and correlates with renal involvement. The other is highly specific but does not track with activity. Read the command. Which two antibodies? Antinuclear antibody is sensitive but not specific, and the specific ones each carry a distinct meaning. Antinuclear antibody is the screening test for lupus. Highly sensitive, so a negative result largely excludes the disease, but positive in many other conditions and in healthy people. The two specific antibodies are anti-double stranded DNA, which correlates with disease activity and particularly with lupus nephritis, and anti-Smith, which is the most specific of all but does not track with activity. Using the sensitive test to rule out and the specific test to rule in is the principle being examined here. The correct answer is A. The other pairs listed each belong to a different disease and are worth recognizing on site: anti-centromere MARPS limited scleroderma and anti-scale 70 diffuse scleroderma, anti-Rowe and anti-Lamarck Sherbin syndrome, and carry a risk of neonatal heart block, anti-mitochondrial MARPS primary biliary cholangitis. Note also the anti-phospholipid paradox. The lupus anticoagulant P prolongs the partial thromboplastin time in vitro while causing thrombosis in vivo. If you see a positive antinuclear antibody leads to move to the specific antibodies to name the disease. Which pairing is correct? Two reactions are compared. Reaction 1, 7 days after receiving equine antitoxin, a patient develops fever, urticaria, arthralgia, and glomerulonephritis with low complement. Reaction 2, hours after an intradermal injection of antigen into a previously sensitized patient, a localized area of edema, hemorrhage, and necrosis appears. Read the command. Which pairing is correct? Two type 3 reactions, one systemic and one local, separated by timing and by where the complex is formed. Serum sickness is the systemic form of type 3, hypersensitivity. Foreign protein circulates. The patient makes antibody against it over about a week. Complexes form in the circulation and deposit in vessels, joints, and glomeruli, producing fever, urticaria, arthralgia, and glomerulonephritis with consumed complement. The oddest reaction is the local form. Antigen injected into a site where antibody is already abundant forms complexes. In situ within hours, causing local edema, hemorrhage, and necrosis. Choice B reverses them. The correct answer is D. The 1-week latency of serum sickness is diagnostic rather than incidental, and it distinguishes the reaction from an immediate allergic response. The delay is exactly the time required to mount a primary antibody response against the foreign protein, which is why the reaction appears after the patient has apparently tolerated the injection. On re-exposure, it occurs faster because memory shortens that interval. The primary versus secondary principle applied to an adverse reaction. If you see a reaction about a week after a foreign protein leads to think serum sickness, which defect is present? A 6-month-old boy has had 2 episodes of severe bacterial infection with NO-pus formation at any site, and his umbilical cord separated at 8 weeks. Neutrophil count in blood is markedly elevated even between infections. Read the command. Which defect? 3 neutrophil disorders can be told apart by what the neutrophils fail to do. Leukocyte adhesion deficiency type 1 is a defect in the CD18 integrin subunit, so neutrophils cannot firmly adhere to endothelium and therefore cannot extravasate into tissue. The consequences are exactly as described, infections without POS, because neutrophils never arrive. A markedly elevated blood neutrophil count because they remain trapped in the circulation. And delayed separation of the umbilical cord, which requires neutrophil-mediated tissue remodeling. Chronic granulomatous disease, by contrast, forms pus perfectly well. The neutrophils arrive and simply cannot kill. The correct answer is E. Separating these 3 by the step that fails is more reliable than memorizing their names. Adhesion deficiency fails at arrival. Chronic granulomatous disease fails at killing. And Shediac-Higashi syndrome fails at pH fusion, presenting with partial albinism, peripheral neuropathy, and giant granules in leukocytes. Myeloperoxidase deficiency, choice B, is the common and usually harmless one, since other oxidative mechanisms compensate. If you see infection without pus and delayed cord separation leads to think leukocyte adhesion deficiency. Which process is occurring? 3 weeks after allogeneic bone marrow transplantation, a patient develops a maculopapular rash on the palms and soles. profuse diarrhea, and rising bilirubin. Read the command, which process? In transplantation, the immune attack can run in either direction, and the organs involved reveal which way. In solid organ transplantation, the host attacks the graft. In bone marrow transplantation, the graft is itself an immune system, so donor T cells attack the host. Graft versus host disease. The target organs are characteristic and are all epithelial surfaces with high antigen exposure, SKN, producing a maculopapular rash that classically involves the palms and soles. GUT producing profuse diarrhea, and LEVAR producing rising bilirubin. The triad in a marrow recipient is essentially diagnostic, and choices A, B, and E all describe attack in the opposite direction. The correct answer is C. 2 practical points complete the topic. Graft versus host disease can also follow transfusion of non-irradiated cellular blood products into an immunocompromised recipient, which is why such products are irradiated to inactivate donor lymphocytes. And the same donor T cells that damage host tissue also attack residual leukemic cells. The graft versus tumor effect. So a limited degree of the reaction is associated with lower relapse rates, making its suppression a genuine clinical trade-off. If you see rash, diarrhea, and jaundice after a marrow transplant, leads to think graft versus host disease. 50 questions done. 5 discriminators worth carrying out of this session. Every one of those separated two entities that produce the same clinical picture through different mechanisms. Name the mechanism, and the answer follows. Next in the series, pharmacology and toxicology. Step logic. Learn how to think, not memorize.